It's all in my head.
Meh.
Thanks for signing on a little bit early. We're waiting for a few more people to arrive. Will, thanks for signing on. Taylor, I can see you. Arena, Don, Bonnie from the Greenbush team, thanks for being on. We'll get started here in just a couple minutes.
Great.
Oh, you got, yep.
Hey, stranger.
Hey, how are you?
Good.
You excited?
Yes. Yep.
It's one more day, right? One more business day.
Yeah, I know. I know. We're trying to get some furniture in at the same time and it's not going so well. You know, it's just the timing of everything. It's like, maybe by the back end, we'll get some of it.
Yeah.
But yeah, it's going good. I think we're ready. We have a plan.
I heard the owners of the lot that we're parking
Yeah.
on today. The owners of the lot that we're parking on today.
Yeah.
And the owners of the lot south of Greater Adams. And when I saw the email pop up, I thought, here we go.
Then our two primary agenda items are some presentations from folks working on workforce and training and education pipelines. So we've got one of those people on now, so that'll be helpful. But she's got 2:00 hard stop. I think Taylor, is that right? And then our other presenter can't be here until after 2:00, so we may do a little have a little flexibility in the agenda so we get both of their presentations in. And then as we're getting close to our September final deadline for the report that we have to produce, wanted to go through the recommendations that we've been cataloging over the summer from the subgroups and things that we've talked about here in the group, just to see if we're on the right track with the writing of those recommendations, other things to add, things we haven't included yet. But so we'll spend some time on those recommendations as well. But with that, we'll look at the minutes. You should have gotten those earlier this week from a fairly short meeting that we had in July. But are there any corrections, deletions, or substitutions in the minutes that anyone has? If you're online, if you could maybe raise your hand or just unmute yourself and chime in if you've got something. If you're in the room, if you could use your microphone for the benefit of our Zoom attendees.
Could you change association?
Yes. Sorry about that, Mary. Any other changes to the minutes? Commissioner Lopez as well. Good to see you, Sarah.
Hello.
Not hearing any other changes to the minutes. Could I get a motion to approve?
So moved.
Got a motion from Claudio, I believe, a second. Mary Jones seconded. Any objections to approving the minutes? Hearing none, with the one change of Association to America, we'll have the minutes designated as approved. We'll go into some project updates now from the team. Tanya, if you would want to go first, and then I've got a couple of things, and then we've got Basil Sherman from Pulse Design to talk about some design updates as well.
Good afternoon. Are you able to switch me over onto the presentation? Oh, perfect. Thank you. Okay, well, good afternoon. I have a milestone update to share with you this afternoon. So there's three things that we are working on for this project. That's land, design, and construction. And so the milestone that I have to share for you this afternoon is on land. And so I'm going to give you the updates, but I'm going to kind of focus between these two slides for the depiction of the property. So as you're aware, we were working on the MacArthur Meridian property. And right here is the site plan that the design team put together showing the MacArthur Meridian and what that site plan will look like with the mental health hospital at that particular location. And so you can see the kind of the outline of the hospital there towards the north part, and then towards the south part there is the parking lot area with the three access points. The middle access point, let me see if I get my pointer working there. That middle access point then being for the public and employees, the left access point being here for the forensic and delivery area, and then this eastern access point here that would be for the acute patient drop-off, and then, for the Custer Street access for anyone that would be going to the One Rise location. I'm going to focus on, you can just keep your eyes on this particular slide, but what I'm going to focus on, I'm going to be reading off of slide 3. So if you will recall, the City Wichita City Council approved the zoning for the mental health hospital on May 14th. And then on May 16th, the governor and the state legislature approved the additional $26.5 million of state general funds, which allowed us to be able to expand this to the 104-bed mental health hospital. So total funding for this particular project is $107 million in totality for this project. So last week, the county commission approved the land donation for us to be able to move forward with this land at MacArthur and Meridian. And so to date, the county has performed environmental, geotech, and property survey of this property. And so just to point out, our boundaries are this first line here, and then down to Custer Street and along here. And then the second line here is our retention pond area. And so this is the map over here is just, I like this map better because it has colors. But again, this is our boundary line here, the Custer Street, and then this is MacArthur Avenue, or MacArthur Road, excuse me. Okay, so with the land donation agreement, Lang Community Foundation donated 11.72 acres, and that was valued at $1,424,359. We're going to close on this property either on or before August 31st of this year, and the state will pay with state general funds. So this is not going to be ARPA. This will be state general funds, and that will pass through to the county. We will be paying $40,105 to Reese Nichols. That is our county designated agent. So they're our real estate broker in this transaction. We will be paying all closing costs, and then we will deposit $180,680 into an escrow account. And so let me just explain what that is. The city of Wichita waived a letter of credit requirement for infrastructure development for the build out of our property and for Reserve B1. That was the retention pond area. So typically a letter of credit is required from a developer. However, the city waived that on this particular property. If the purpose of the regional mental health hospital is not fulfilled, the waiver then would no longer be effective. So in that case, if the city later requires the letter of credit or security from Lang, the county would then have to pay these liquidated damages of up to $180,680 as compensation for costs and damages to Lang related to those special assessments if Lang provides proof of those associated costs. However, in the event that we continue with the mental health hospital and the construction is completed, we would take that $180,680 that's in the escrow account and just apply that to the special assessments. So again, that $180,000 is just going to sit in the escrow account. There will be $1.4 million that's estimated. I think construction will let here very soon on the special assessments for our particular property. However, it is estimated, and that is for the access road, sidewalks, retention ponds, utilities, water distribution, sewer, and stormwater. And the state will pay these special assessments over 15 years as part of their operating funds. And so, again, that's on the milestone of the land. And so I think that's something to be celebrated on this particular project. And so let me just move into design and construction timeline. Pulse Design Group and Basil will be talking here after me, and Tesserae. That's our architect and engineering team. They have completed design development as of July 26th. And so our timeline then moves into construction documents that will be complete mid-October of 2024. And construction documents are what we put out for bid. So that's what contractors will be looking at. So those will go out to bid October 24th. They will be due back to us, to the county, to Sedgwick County Purchasing, November 26th. And then we will review those bids and select a contractor December 5th. That will go to our internal bid board team for recommendation. And that will then go to the county commission for approval on December 11th. And then contract would then be signed December 19th. And then again, we're sticking with our timeline for construction to begin February 2025 and for that to be completed August of 2026. So approximately 18 months. And then I was going to share some renderings. However, I understand that Basil's on there, so I'm going to let him share those beautiful renderings that was also shared at the town hall. So I'm happy to answer any questions that you might have.
Any questions for Tanya about material she presented?
I just have a quick question.
Sure.
And this is
Ready?
maybe,
Latasha, could you turn your microphone on just so others can hear you?
it's just a simple question. The 18-month for construction,
Mhm.
how did that come to be? I was just curious.
Basically because of the ARPA timeline.
I know.
Yeah.
So I was just wondering,
Yeah.
is that going to be in consideration because of construction companies in town are up against other projects they're working on? I'm just wondering what happens if, not to be
Yeah,
go
no,
plan B, but I'm just
yeah.
wondering how you guys are working through that.
Yeah, so that's a great question. So a couple things. One is, and we've not done this before, but we are going to, prior to us going out to bid, we're going to kind of pre-market that
I wonder, yeah.
and kind of basically say, okay, to all contractors, please be aware that we're going to go out to bid on such and such date so that they can kind of have their teams ready as soon as that hits the streets, that they are able to grab those construction documents and then be ready and able to turn that in. And so we're kind of enticing contractors. The other thing is we are going to, as we do this construction, the first part that we're going to be paying out is the ARPA dollars, so that if construction is at any point has to go past that timeline, we're okay.
Right.
The other piece that we're doing is we are asking when the bids come back, we are asking for the base bid to be strictly construction. The other thing we're going to do is we're putting in alternates that the alternate be the FF&E, furnitures, fixtures, equipment, and medical equipment, so that there is a second piece that if it takes a little bit further for them to basically finish out the construction, then that can be a second part of that. And then if it takes a little bit longer, then we're okay.
Great.
But again, because ARPA has to be complete by that 2026 deadline, it's all kind of taken into consideration in
But
that timeline.
essentially, you're making a requirement in the RFP that if you're going to go out for this, you have to meet these deadlines.
Correct.
Yeah.
Yeah.
Question. I think I saw Claudio's hand was up and then Senator Reddy's hand is up. But Claudio, if you still have a question, go ahead.
It's not really related to the project itself, other than we probably should bake in some date for a groundbreaking.
Yes.
This will be a very favorable event for the community, and I think that would be something to factor in, even though it's not going to affect timelines.
We've talked about that a little bit with the county because we're probably looking at a January or February date in a pasture. So if anybody has access to a tent or anyway, we have talked about that for timing, and I think once we get the bids in, we'll get a better sense of what a good date would be for that, because it is something we'll want. We have a lot of people to invite and recognize to get it that have gotten us to that point when we break ground. But thank you for calling it out. But we are looking for a tent. If somebody's going to look for a tent. Senator Reddy.
Yes, thank you, Scott. Yeah, I think all of it looks good. I just have a question about letter of credit was waived, I think is what she said. Could you just explain to me a little bit the intent of a letter of credit? Because I might just be making an assumption. I'm thinking it's to check if what their credit is and if there were any causes of concern. If that's not it, can you just explain to me what the letter of credit is typically used for in Sedgwick County?
Sure. So the city of Wichita will typically require a developer to put down 35% through a letter of credit or security on a particular parcel that they're developing. In this particular case, because it was the Sedgwick County and the state that are developing on this property for a mental health hospital, Lang approached them and asked them if they would consider waiving that, and the city had no issues knowing that we were placing the mental health hospital. However, it was Lang who basically wanted that assurance in there if we did not proceed with putting the mental health hospital, and they would then later have to come in and be required to then put up that letter of credit, understanding that they've now developed and put in those special assessments for that property, that they then would have to come back to us for those liquidated damages on that property, if that makes sense.
Yes, I understand. So it's kind of reversed. Okay,
Yes.
I get it
Yes.
now. Thank you.
Yes, thank you.
Good question. Any other questions for for Tanya on what she presented. She'll be around for a little bit if something else comes up. Before I jump over to Basil, I just had a couple of items I wanted to update the group about. Tanya talked about the timeline of where we are. So the architects are working on the construction documents, but we're still continuing some kind of more detailed design work on the interior of the building. Some of the security systems in particular is something we've been working on quite a bit this week to talk about what kinds of technologies are available, what we have to build into the building to use the technologies that are available. So there's still some of those things that'll happen even while they're developing the bid specifications and fits and finishes as well. And you'll see some of that on the renderings. Because of the cycle that we're in as a state agency, we have to put our budget requests in for the next fiscal year that'll start next July to the governor's office in September. Our project, because of the timing, we are building into our budget submission as an agency, the plan for staffing up initially for this hospital. So some of the administrative staff we want to bring on during the construction process. And then when we would actually open is inside this budget window. So we'll have, I think when we meet in September, some more to present to you all about what we've included in the budget, what that looks like, how it fits together to the overall operating plan. But that's happening over the next month or so. And then kind of a key part of that is the hiring plan as well. So we've got our list of what we need for staffing. We need to deconstruct that a little bit and start filling some of the initial positions, even still in this fiscal year to have people. We're certainly dedicating staff time to the project, but as it starts to become more real and we're starting construction, we need to have more a team dedicated to the project. So we'll talk more about the hiring plan as we get into our meetings in September and October, just again, so you can see that in a little bit more detail. So that's what we've been working on. I should stop and see if there are questions for me while Basil gets ready to go through his design update. Any questions for me?
I don't have any questions. I just want to say congratulations on hitting that significant amount.
Thank you. No, it's a big deal. A lot of work by the county team here and cooperation from the city, of course, and Lang and the One Rise team as well. So it's a lot. It is important to note. So Basil,
Yes, sir.
give us an update on the construction and design.
Absolutely. Is somebody going to throw up what I'd sent you earlier today?
Yes, just a second. Nope.
It's a PDF, so you can scroll. It's not a PowerPoint, it's a PDF.
Okay.
So you just need to scroll.
Okay. We're just gonna figure out how to advance through it, Basil, but go ahead and
Sure.
and start.
So
Yeah, go ahead.
yeah, so quick update. We're going to basically go through, this is actually it's the same slides that were just the architectural slides from the town hall that was done. What was that? 2 weeks ago now? Is that right? 2 weeks ago now. But either way, when if we get it advanced here, we'll there we go. So we're gonna kind of site plan, kind of start way up, sky view and work our way down into it. So go ahead and scroll down. So Tanya kind of already talked about the site. I won't belabor that, but here you can kind of see the quick trip in that area we talked about. Here's the site plan that Tanya showed. So a couple notes on this that we talked about that are worth noting is there's kind of a dual layer of fencing around the facility for security. So you've got an outer fence that will kind of fence off the property outside of but it fences off, and actually outside of the property, I should say, it fences off the building so that the public still has access to the parking lot and makes it more open and welcoming to visitors. But then there's also an inner security fence that will actually be a security fence from a behavioral health anti-climb retention that fences off even tighter into the building for should anybody manage to get through the security measures we have in the building, they would still be captured by the first layer of fencing. So basically, in addition to the security measures on the building, there's 2 layers of fencing somebody would need to be able to overcome in order to get out of property, out of the hospital. Yeah, so then the next view you kind of see here is kind of a bird's eye view, kind of almost like if you were floating over just in front of the Quick Trip, looking back at the facility. So you can see the patient wings, one of the sets of the patient wings off to your right there. You can see the main front door, kind of the upper story, that's the administrative area you've seen for some of the plans you've seen. And then as we kind of advance to the next slide, this is transitioning to what would be the front door. So the stamped concrete area you see there to the left is kind of a covered, or not covered, but rotunda drive area for drop off. You see the front door, as well as the front glass there, sorry, and then some of the materials we're using on the facility that kind of emulate the kind of the brick that a lot of the state facilities have, and is kind of native to, I guess you'll say it, to the Sedgwick County and Wichita area, as well as some natural wood tones that are above the glass. But again, kind of that's what you would see as if you were walking up to the front door. You want to go down next one, it's just taking a little bit step further back. You can kind of see that rotunda drive area, but now you're kind of in the parking lot. You get a context of kind of that sweeping upper roof. Off to the right hand side there, next to the roof, is a covered outdoor area for staff break, but separate again from the ground level, separate from the patients, and then landscaping and whatnot. So you can kind of see how the areas that are intended for deliveries and patient transport are screened from sort of that public realm, that public view, as you kind of come up and into it. So the next slide, I think this is a plan that most of you, I'm sure, if not all of you, have seen before, but you can kind of see the wings of the building. You can now see on this plan a little bit more developed, that dock area where our generators are going to sit. In the bottom left, they're kind of in the white, they're not colorized, but that area is actually sunken so that you'll get a little bit less or more sound absorption and less direct view of that where the generators sit. And then there's 4 courtyards and then the 2 gymnasiums in the space. One development to this relative, since you've last seen this, just to kind of highlight, we are going to be hardening all of the patient wings, what we're calling the fingers, for a 250 mile per hour sort of F5 tornado wind, in addition to having the actual gymnasiums themselves hardened for that. That will allow the patients to be protected in place during a storm event, and then the staff to be able to seek refuge in the actual gyms. And then obviously, if for some reason, anybody was in transit or whatnot, and it was easier or safer to get them to the gyms versus the fingers, they'd have that option. But now the patients will be able to be placed in their room. And Scott, I believe your team is kind of working on that kind of disaster response plan, or that emergency response plan. But that's something that's been finalized since we last talked. So the next one is kind of zooming in on the second floor and shows again that kind of administrative area. You can kind of see that form that you could see from the renderings. But all administrative zones here. Staff have access to a walking track around the gym. So one of the gyms is actually also a staff amenity, but it'll be screened from patient view down below.
Hey, Scott, is there any way you can make that larger? All we're seeing is the large screen, the small screen in the top. Maybe I just don't know how to do it.
I think you can double
There you
click.
go.
Yeah.
Thank you.
Okay. And then up here, in addition to the administrative spaces, there's training, education, the central materials delivery, pharmacy, as much space that's not immediately patient critical adjacent. We've pulled upstairs on this floor. Some of the mechanical rooms and whatnot that are up there as well, serving the mechanical systems to the building. On the next slide, this is kind of first view. This is what our front lobby would look like. So you've just basically walked in through the vestibule. To your right, you see this sort of greeting / security area. And that person you see kind of looks like they're getting ready to walk through a door. That's actually where the metal detectors will sit. So those are in kind of formed and shaped into the walls, rather than just having a metal detector you walk through. It looks a little more architecturally pleasing. You'll see kind of a consistent thing here with these large natural graphics that are designed to kind of integrate artwork into the design versus just kind of be pasted onto the walls. There's a small kind of vending coffee area in the back there for visitors. And then kind of across from that's actually where the public toilets are. But yeah, so you can see windows to the left. Those windows you would have been what you saw from the front rendering view. So main lobby. Then as we advance on, you've got just a close up of the fingers, which again, you guys are mostly familiar with, but just kind of sort yourself. The renderings you're getting ready to see are kind of highlighting these zones. So as we move on to the next one, yeah, you can keep going. That's just the forensic side. So this is one of what we call our day rooms. So this is actually that shared area in front of the nurse station. You can see the enclosed nurse station off to your right, enclosed with safety glass, but with all view 270-degree view around the whole day area from what you saw on the floor plans. Elevated vertical ceilings in here to help the bigger space feel bigger, but also allows us to work in some softer spaces, deinstitutionalize, the space, some high windows that are allowing daylight in, but you can see kind of the little group seating and therapeutic areas for them to do day therapy and group therapy on the unit. In addition to those embedded graphics and those floating discs you see there are actually an acoustic material that will allow keep the kind of the noise and the volume down and actually knock down some of the otherwise louder noises you might hear in the space. The next page is just the other unit. So again, just a different color, same general look and feel. One being forensics, one being the acute. But again, you can see those nature graphics kind of used on the walls between there. Everywhere you see that graphic in this facility is actually a wall protection material. It's not just like a wallpaper or a paint or a wallpaper. So it's actually designed to be hit, to be scratched, to be punched and kicked without being marred and defaced. So it'll last. So it'll actually have durability, so that 3 years after opening, it still looks like a good quality natural graphic. Then the next view you have is actually kind of turning down and looking down one of those fingers that we call them, one of the patient wings. So you can see we've worked in these nooks for patients to kind of sit if they want to be a little bit more removed and don't want to participate in a group. They can sit and isolate a little bit, but also still be visible from the nurses looking down those wings because it's not quite deep enough for them to hide in. You also see the window where a staff member can look into the patient room and observe a patient, make sure that they are still in a safe place and not doing anything they're not supposed to. So there's actually been some studies on these little, what I'll call them nooks in behavioral health design, and that it actually helps patients self-regulate before they completely elevate. So we think those are going to be a really great positive for the facility. Next is just, again, the other unit. So this is the blue unit, and you'll see the graphic at the end of the hallway and then the blue nooks. The following one you see is the inside one of the patient rooms. So again, you can kind of see it where their desk and kind of bed all flow together. It's a high durability piece of furniture there. But the bed positioned so that when a nurse looks in if it needs to check on a patient at night while sleeping, they can see immediately on the bed that the patient is where they supposed to be. You can see how we've kind of created, even though on the forensic side we need those toilets open from a visibility and security standpoint, it's still a defined zone. It's just not in the room, like you might see at some of the existing state hospitals. And it's also been designed such that if in the future there's ever a need to change patient populations in here, you just re-erect that wall and you're back to having an enclosed toilet. So it should allow for longer term flexibility. And then again, you'll see up on those soffits a little bit of that graphic tied in where it's high enough that it can't be overly fiddled with, but it again brings a little bit of art into the patient room scale. And then, yeah, that's the last rendering. As Scott said, this is pretty close to the final. We're done with DD sign off, but this is one of the final details we had to get through was the kind of the finishes and then a few light lingering security kind of low voltage items. But that's where we're at. Any questions?
Questions about the design or renderings or?
I have a question,
Yeah,
Scott.
go ahead.
Maybe I should know the answer to this, so I apologize if everyone else in the room does. But can you tell me, as far as like safety levels and various wings and like the compliance? So who actually officially says this is within compliance as far as how this design is, and this is what we need, and this is the level of security or best practice, like, who is the final say in that? Like, how does that get determined? Does that make sense?
Yeah, I think so. It's a really, really good question. So the standard we're trying to meet in this facility is that we would be able to be certified by Medicare and Medicaid for services in a acute psychiatric setting. So that means it's got to meet the same standards of either accreditation or certification that we have at Osawatomie and Larned. A lot of those things are related to ligature resistance and some of the policies and procedures around how patients are treated and respecting their rights and how treatment's delivered, the amount of active treatment that's available. Some things are clinical, some things are physically in the space. And so the design that you've seen meets everything we've been able to find in terms of the physical space environment that we have to do to be able to be certified. So that's what we're building towards.
Okay, so is
Yeah,
there
and-
a formal process? Sorry.
Yeah. Basil, go ahead.
No, I was just going to tag on. So to that end, there's kind of two paths to sort of making sure. Well, the first thing is obviously making sure we have it designed right. So we have a bunch of codes and guidelines. There's called the FGI guidelines for healthcare construction, but also just our experience having done this. But we bring all these and some there's 3 or 4 behavioral health guidelines that are kind of industry standard for designing of these kinds of spaces, from a patient safety, staff safety, security standpoint. We follow all those doctors through those do design, but once we actually put them out, both the city and the state have reviewing authorities that will review it for compliance against those documents. The fire marshal will review it. KDHE will review it. And then ultimately during construction, the design team has it on our contract to ensure the contractors are building it to that level. And then ultimately there is a final inspection done for whether it be CMS or if it's Joint Commission who does accreditation, that come in and review and certify that, yes, this was built correct and it's safe to treat patients.
That was the short answer. So KDHE will be the state agency that will inspect it, both for life safety and as a hospital. That's the state licensing authority. We're working with Larned is accredited by the Joint Commission. And so that's another standard that we could meet. We've talked to the Joint Commission accrediting body as we're building just to see what suggestions they had. And they actually have a consulting arm that's separate from the people who do the accreditation reviews that help hospitals in different phases of construction become accredited. So we're working on a contract with them to actually help us with the document review. Actually, they've offered a whole suite of services up to and including inspecting the final thing, to kind of a pre-survey inspection. So we're working with them on what that might look like to make sure that as we're building and as we're designing and building and figuring out policy as well, that will be able to be accredited at some point in the future.
So when does it go to the state for, like, when did these renderings and all the components, all the, nitty gritty details, when does it go up for review to make sure that, we've crossed all the T's, dotted all the I's?
So Basil, correct me if I'm wrong, or Arena's on too, our kind of other person that's an expert. I think they have to look at the plans before we would start construction, and then they do a 50% review. Is that correct?
Right. So yeah, so that if you look back at the timeline that Tanya alluded to earlier, when it goes to bid, it also goes to permit / authority having jurisdiction review. So it'll go to the state, both state agencies, fire marshal and KDHE. It'll go to the city for city review. The codes are actually different, so we have to design the most stringent between the 2 or the 3 technically. And then we have to have sign-offs from all 3 of those organizations. We have to have KDHE sign off, state fire marshal sign off, and city / county fire marshal sign off and Department of Plan review before a permit can be issued for construction.
What happens in the unlikely event that somebody comes back from all of those review bodies and says, hey, we really strongly encourage you to change this specific aspect, or I think you guys need to come back and look at this, or this is missing. What happens to the timeline, or how long does it take them to review? And in the event that something like that happens, does it really disrupt what you have going on when you're?
It can. Again, what we've been trying to do throughout the design and construction document development is anticipate those things and then build to the higher standard as near as we can figure out. But that's a possible risk area depending on. Hopefully, those things will be identified when they review the plans before we start construction.
Great.
But
Well, have you been to plan review
Yeah.
yet to show them where to benefit? plan?
Yes.
Okay.
Yeah. So, well, yeah, that's what I was going to say. So we've done some pre-meetings with them. We've actually set up a pre-meeting with the state to kind of restart these. We know Brian Love at KDHE very well. I've worked with him for close to 20 years probably. But I think the short answer to your question is every reviewing authority will always have at least a comment or two. That's just the nature of reviewing authorities. But we, in my experience, in my career, very seldom have major things missing because we design to every I dot and T cross when try to get anything past them. But also just to kind of clarify one thing you said, they don't get to really recommend things. Either it's required by code or it's not. So just if they don't like something or don't like how something is done, if it's not a code requirement, they're not really allowed to ask for it. So as long as we're designing to code and to the sort of minimum standards, that's really what they're reviewing to. So whether that be the ADA, handicap accessibility, the NFPA 899 medical code, life safety code 101, or IBC, et cetera, depending on the different codes we have to apply to, FGI, it has to be required in one of those aspects of it in order for them to actually ask us to do something, if that makes sense.
Yeah, that answers my question perfectly. Thank you very much.
good question. I think yeah. Senator Reddy.
Yes, thank you. No, I think it was very well presented. My question is at the beginning, I think Tanya mentioned it's $107 million total for the project. Does that include the furniture and everything? I understand the whole design and concept of the interior, but I think facilities need certain types of furniture. So does that $107 million include furniture?
It includes all of the interior furnishings, medical equipment, and any equipment that we're using in the building that the contractor is going to provide. So we do have a book of what equipment is going to be included in the bid event.
Excellent.
And
That's
that
what I
includes the
wanted to know.
furniture.
Yeah, so I just didn't want another bill. Okay,
Yeah.
thank you.
Sorry, Scott, just
Yeah,
one last question. Does that include any replacement and reserve accounts? Like I know typically like somebody will set aside 20% because of overages or unforeseen things, or I'm just wondering, are you guys taking that into consideration when doing this construction?
We've got a project contingency in the budget that maybe Baszler Tiny can describe it better than I can. I mean, I know what a contingency is, but there are some things that we want to say there are unexpected things that will happen that we want to have some money reserved for. There probably are some change orders that will happen, but we want as few of those as possible. So we don't want to really advertise how much we're holding in the project for those circumstances so that we get as comprehensive of a bid as we can at the front end. Is that a fair way to put it? Okay.
Yep, exactly. Yeah, the master budget was put together, has contingencies held in it. Now, you never know what might happen during bidding and all that, but yeah, we've budgeted around contingencies in that. But to Scott's point, we don't typically try to advertise that because it kind of opens up. Oh, they've got plenty of yada yada. So,
and we'll try to we'll be clear about what's not included because, like the special assessments for the site utilities and infrastructure. I mean, that's a cost we could have rolled into the construction budget, but we decided since it's it's a cost of the being on the site, it makes sense to spread that over the 15 years and make it part of the operating cost of the budget. There'll probably be some other things, kind of smaller equipment or pieces or things that are disposable that we'll buy as part of the operating budget. But we've kind of gone back and forth on that list and tried to focus on the things that need to be in the building when we want to occupy it. In the construction budget. Good questions. Any other questions on those project updates? Okay, wanted to get an update about the town hall meeting that we had in August. So Ryan Vaughn with Learning Trees is going to provide that update today.
Good afternoon. As Basil mentioned, and as I'm sure you're aware, we engaged community stakeholders the third time in regards to a town hall meeting on August 1st, that evening at Campus High School. We had 47 attendees that evening, which included presenters, and then 7 additional viewers joined via YouTube on the KDAD's live stream. That evening, the agenda essentially consisted of Ms. Lopez providing a welcome and opening comments, Ms. Bernan providing the framework or the format for the evening, Ms. Cole, Mr. Bruner, Mr. Sherman, and Mr. Tannehill providing presentations, which each lasted about 10 to 15 minutes each. Essentially 40 questions were presented to the panel with the themes covering governance, community engagement, operational logistics, staffing, infrastructure, collaboration with educational institutions, and community impact. And then following the Q&A time, we once again had a QR code and paper surveys that people could offer up feedback and just let us know their thoughts. 19 folks chose to do that. 3 of those were paper, and then the other 16 were done digitally. From that feedback, the general themes were basically there was a hope for enhanced mental health services throughout the community, and just excitement for the impact that this project would have, that the hospital would have. And folks emphasize the ongoing concern for adequate workforce and the importance of transparency and collaboration and planning. Of the folks that submitted feedback, the 3 top basically zip codes that were represented were 67217, which is that MacArthur and Meridian site, and then 67216 and 67215. So right there in that general area. Generally speaking, I feel like the tone for the evening was very engaging, very positive in nature. And the questions were spot on.
Yeah, I agree. The one, we did have Matthew Tannehill from One Rise on the panel as well and present, and he got a pretty good number of questions just about what the future of One Rise is and what the planning efforts going into that. And I think he gave a fair representation of what their vision is, how it fits with our project and other things they're thinking about. But that seemed to be as well received as anything that we said about the project. Thanks, Ryan. Claudio, your hand's up.
So maybe not a question about anything that was discussed that evening, but just a thought that came to mind is, has there been any conversations around having some sort of organization, some attention to having input from the residents, maybe like an advisory or some groups as it comes online, just to keep the neighbors sort of involved and informed of things that are happening? I mean, we use some of that, like with our oncology service line. It's like an advisory panel, and we share what's going on, and just to be good neighbors and to develop our processes going forward. But it just keeps that open line of communication on a go forward basis is kind of the thought.
No, that's a good suggestion. Actually, we got a question very similar to that in the panel, and I feel like we did a pretty good job answering questions, but I got that one totally wrong. The answer I gave was that there's the governing body. Anyway, I went the wrong direction with it. The answer I should have given was exactly what you were suggesting, Claudio, because at Osawatomie and at Larned, there is a citizens advisory group that is formed, that the superintendent hosts, that has folks from the mental health center, the local law enforcement, typically Chamber of Commerce, economic development officials, because they're really talking about how the hospitals in Osawatomie and Larned fit with the community, other healthcare providers, school district comes. So that's a model that we'd repeat here as well, which is more of that kind of citizens advisory, public feedback input group. So I didn't say that in the town hall. Thank you for giving me the opportunity to correct that in this meeting, but we'll have some kind of a have to think about the membership and that it doesn't become unwieldy. But at Osawatomie, that's been a really effective group to talk about program changes at the hospital and share information. I think it's a really good suggestion for this facility as well. And actually, as this panel kind of transitions out of our charge, that would be a kind of natural place for that kind of public input to go as we're in the construction process. Any other questions about the town hall? See any? Okay, thanks, Ryan. I think we'll go into our first presentation about on workforce. So I invited one of my co-workers, Taylor Bremer, is the Assistant Behavioral Health Commissioner for KDADS, and she's leading the agency effort on a multi-state project around behavioral health workforce. So I want her to talk a little bit about the project. I think it'll mesh well with the presentation we're going to have about the Behavioral Health Center of Excellence as well. So Taylor, if you wouldn't mind jumping in there. I know you've got a 2:00 meeting, so hopefully you've got enough time to get into your presentation.
Yeah, it's fine. Thanks, Scott. Hi, everyone. Thank you for inviting me to this meeting. So I'm going to talk a little bit about what we're doing at KDADS with other agencies and entities to help really improve the workforce for behavioral health here in Kansas. I know that's something that we hear a lot about, especially when it comes to a lack of nursing or a lack of professionals who are able to provide therapy, things like that. And so what Kansas did is we applied for this, what's called a policy academy. Scott, do I need to, oh, there we go. Okay.
No, I've got it.
Thank you.
Sorry, I wasn't paying attention.
No,
Go
that's
ahead.
okay. So I don't know actually how many states applied, but 5 were awarded this opportunity to participate over the next 2 years with what's called NASHP, but that's the National Academy for State Health Policy. And what we do is we partner with them and they provide technical assistance. They really are the piece of accountability to ensure that the goals that we have established within our application that we submitted are accomplished within that 2 years. So really what we do is we look at what we need to develop. So state level behavioral health workforce improvement strategies, things like that. And then we work on identifying SMART goals in order to achieve those. And we do that with numerous, again, entities. So we have a few individuals on our board, like the regulatory boards. So we have KBOR, the Kansas Board of Regents, we have the BSRB, and then we're reaching out to other organizations like the Board of Nursing to ask some questions to figure out where we need to target specifically. So within the Policy Academy, really the purpose is for us to, again, we develop these goals when we submitted our application. And from there, they help us move forward, right? So we're able to focus on numerous different things, whatever we want. And so as you see from this slide, again, it's a lot. We can go any direction that we want in order to reach our goals. So that could be changing some regulatory practices so we can work with legislators on that, saying, hey, this is a barrier, maybe not. We can improve telehealth and teleconsultation extenders. So if we're seeing barriers with that, that's what we would go through. Recruiting and retaining licensed workforce. This is one of our goals is looking towards, right? So we're wanting to see, how do we recruit these individuals? How do we retain them? And what incentives are working in other states? And how can Kansas bring that here to help improve our workforce? Another thing that we're looking at right now is effectively incorporating an unlicensed skilled workforce, right? So you'll hear a lot about LMHTs. BHTs, things like that, on how we help bring that to light, right? So those are just a few ways. Yes, Will, I will answer your question. Otherwise, I'll forget.
Taylor, I can't see any questions because I'm in the
No,
room.
that's
I can see the
okay.
screen. So go ahead and answer if you've got a question that you can see from the Zoom.
Will, did you have a question?
I did. Representative
Okay.
Carpenter here. So was there a conversation about privatization in this academy?
Could you explain a little more? I do not think we've had conversation about privatization. But I would like to know more.
The purpose was more about workforce development and training, not so much about hospitals. It more community, inclusive of community mental health center or outpatient workforce and behavioral health workforce that are in facilities. But it's more about the workforce and training pipeline than operating facilities.
Okay, well, you know where I'm at on this privatization, and I think that we're going to miss the boat big time if we don't explore it. I'm not saying we should do it or anything, but we should do our due diligence to make sure that privatization is off the table and is not a good fit for us. But until that's proven, I think we need to take a look at it. And you know, Scott, I've been your ear a long time on this, so.
Sure.
Thank you.
Great question. Okay, so how does the Policy Academy work? Again, we talked a little bit previously, but really what they do is they provide the resources to help support us in the development, implementation, and the strengthening of our cross-sector strategies. So again, we're working with a whole bunch of entities. We don't necessarily always all speak the same language, meaning that whatever is going on with maybe nursing, we're not always aware of. And so that kind of helps bridge that gap. Who are we not thinking of bringing to the table when we're trying to develop strategies to help improve our workforce? So they really help us think outside of that box and say, who else needs to be here? Who else needs to be having that conversation with you? Additionally, we will be going to Nashville here in September on the 9th, and we will be then able to network and talk with other states to see how they're working through their workforce shortage, what has worked for them, what has not worked for them. That way we're not doing something, we're not reinventing the wheel essentially, because that does take a lot of time to run up against something that maybe another state realized, hey, that does not work. We can see if it works here in Kansas, because again, we're different from other states. However, what would that need to be, what would we need to change to make that effective for Kansas? And what would their barriers, would those be possible here in Kansas? And if so, how do we overcome those barriers? And again, they provide that technical assistance for us. So this slide just kind of shows you who all is in our Policy Academy. We have tried to get a whole conglomerate, I guess, of individuals. So again, we have the Kansas Board of Regents, we have the Behavioral Science Regulatory Board, we have the Association for Community Mental Health Centers, we have the Behavioral Health Association, and then we have KDAS as well. And I'm working with reaching out to different entities. I have a meeting with the Kansas Board of Nursing and meet with, I believe it's Carol next week, and then a few other individuals to see about how we help bridge that gap, because we're noticing right now that we don't have a very good marketing for behavioral health jobs and things like that, starting in like middle school and high school. So we're going to work with some entities that do like virtual career days to see if we can highlight those different jobs and what they would need to in order to achieve a job that they would want in the behavioral health field. We are also, I had the Kansas Board of Regents pull some data that was pretty interesting. So I wanted to know if we were seeing an increase in individuals entering into and completing a degree in the behavioral health field. And what they were able to pull for me in 2018 to 2023 did show like a fluctuation of different degrees. Again, this could be a bachelor's in psychology, a bachelor's in social work. I believe another one would have been human services. And then it also included master's level social work, psychology, counseling, things like that. And what we saw from that data, again, the very raw data that they pulled, is that we've had since 2018 a 7.5% increase in people seeking out behavioral health degrees, which is amazing. We just now need to know how we connect them to the areas that we need them to be in. And so that's, again, we're using this data to help form kind of how we need to develop policy or how we're needing to support the workforce moving forward. So that's just some of the fun and exciting things that we're looking at. We also pulled the data for nursing as well, and I'll be looking at that too. So some of the Kansas goals that we have are to develop an initiative to address the shortage of behavioral health professions by creating a career pathway with reduced barriers to accessing education by collaborating with the State Department of Education and the Kansas Board of Regents. Okay, again, so that's us trying to figure out those career pathways, which ones are we really needing to have, right? Because if we're trying to send people into being psychologists because we see there's that need, what are those steps that they need to take and how are we helping them achieve that goal? Now, if not saying we have a shortage in psychiatrists, because we all know we don't here in Kansas, right? But if we're saying we're trying to send people into psychiatry, but we don't have that need, then that's not the pipeline that we should be taking. So again, that data is telling us where we need to go. We all need psychiatrists. I was just saying that is the easiest one, but we all need psychiatrists. Kansas, California, all of us. The second goal is to overcome that workforce shortage. We'll standardize additional behavioral health positions, again, that LMHT or BHT, to create courses and certifications that really help us recruit students and potential employees from other states, right? So we're trying to see, because again, we can't always we're fighting different professions all the time, right? Everybody has a workforce shortage. So how do we get creative and start seeing how we can use people from out of state to fill those holes that we have? Or even that unskilled workforce, how can we help reduce some of the burnout that providers are facing because of the work overload that they have? Goal 3 is to generate effective incentives while reducing burdens on providers to assist in retaining and supporting them. Again, how are other states incentivizing their providers? Are they paying for going back to school? What are they doing? Are they giving some type of higher reimbursement rates? Whatever it is, we want to see what they're doing so we can potentially look at doing that here in Kansas. And then goal 4 is collaborating with external stakeholders, such as the behavioral health workforce, higher education, K-12 education, licensure, entities, etc. And then we'll develop and promote legislation that helps specific incentives for that behavioral health workforce and work alongside legislators to enact them. That's our last goal. Mainly because we still just don't know what we don't know. So that's something we're trying to work on goals 1, 2, and 3 more right now to see what we need and how we can help our workforce before we can get to goal 4. So that's a little bit about us. It was a lot. I'm sorry. I talked very fast. Oh, I do have another slide. Just kidding. Sorry, Scott.
I think you did talk about some of these things already, but.
Yeah, I did. Yes. We are going to Nashville. Again, the whole objectives of going to Nashville is just to learn more how other states are doing things, where they're at in their progress, where we're at in our progress, and getting that assistance from NASHA is huge. I've been to a policy academy before for children's behavioral health. And what they do is they really sit us in a room after numerous presentations that get our juices flowing and say, now, from the information that you have, what else do you need in order to come back to Kansas and start enacting this? What else is maybe a barrier that's causing some progress not to happen? And so those are the things that are going to happen on September 9th. Again, it's just a quick day. For sure, I will. It's just a quick day, one day of going over this, and then we come back and we start again, boots on the ground, working on our policies. And we did not know that we received this opportunity until about mid-May. And so we've only had 4 meetings as a group, and we, I believe, have accomplished quite a bit. We've figured out a lot of answers that we had questions to, all because we're able to collect data from a large scale because of NASHIP's technical assistance. So it's been pretty great. Okay, I think that's the last one, right? Yes.
Yes.
Perfect. What questions do you all have?
I don't necessarily have a question. I do have an observation that your Policy Academy work group doesn't include any providers who are living and breathing this every day.
That's a great observation.
Did you, sorry, didn't raise my hand. Did you discuss or mention, I don't think I saw it on the slide, but like mobile units, mobile telehealth, so when I go to my rural communities, they don't have structures for these things for evaluations and such. So I know we're addressing the hospital needs here, but on the preventive measure, or even for those involuntary patients that are outside of our realm, is that part of a discussion where we have mobile units going place to place?
So I think it's more, we're focusing on the workforce and what that would take, right? And for our mobile workforce, it does look a little different. And who would be able to provide those, right? So how do we bridge that gap? Because in rural communities, right, there's a lot of people that don't live out there. So how do we make sure to incentivize that area? So I guess that goes back to, how do we incentivize providers to go to our highest needs? Is part of, maybe not a full answer to your question, but it is something that we're looking into.
Yeah, I understand. Thank you.
That is a really good question, and something we've talked about here before, of where everybody who works in behavioral health or mental health needs more people to provide care, but it's also, we need to provide that care at lots of different levels of being institutionalized or community-based or mobile. So we've got to grow the whole pie. And I think that's part of one of the questions for, looking at what other states are doing too. How do you expand? How do you grow the whole base of providers so that everybody's needs are met, and you're not just taking, by incentivizing one thing, you're somehow disadvantaging. We spend more money on mental health centers, and then SED providers don't have enough money, or the rates are different. So I think that's really there's so many moving parts to think about carefully, that having this kind of relatively broad group working on it helps think through some of those unintended consequences. But I think you'll hear some of those themes again when we talk about the Center of Excellence too. So it's a time where there's a lot of interest in this as a topic, and keeping it coordinated is important. And if you didn't get anything else, I wanted you to see the list of who was participating, because it's a lot of the same people. So it's hopefully we can keep those same efforts aligned as we move forward. Are there other questions for Taylor? Did see we will get the slides sent out when I get back to Topeka. Other questions for Taylor? All right. Thank you, Taylor, for being available. We appreciate your presentation, and we may want to hear from you after you come back from Nashville of what easy solution you found that we can just implement.
Okay. Those are high expectations, but
No
yeah.
promises. Okay.
Thank you all. I appreciate it.
While we're on the topic, Michelle Ponce is online as well to talk about the Center of Excellence. So I think we'll bridge into that presentation if you're ready. I know you were coming from another meeting too, Michelle, so I don't want to.
Nope, I'm ready, but we had our board meeting and I just got back from Salina, but I'm ready to go. Did you want me to share my screen or did you have, looks like you got it.
Yep, they're up now and I'm going to advance the slides for you. If you can just tell me when you want to move through them, I'll be happy to do that for you.
Sure. And I'll start with introductions. My name is Michelle Ponce. I'm the Associate Director of the Association of Community Mental Health Centers of Kansas. Our association represents all 26 of the licensed mental health centers across the state who provide behavioral health services in all 105 counties. Next slide. I was
actually, Joan was going to introduce you and I didn't give her the chance to.
Oh,
so
sorry.
I
Hi, Joan.
Joan, do you want to say anything else about?
Yeah, the only thing I want to say is, when we start talking about this, I just want to say that her boss, our association director, started talking about a crazy principle or a crazy idea about a year and a half ago. And we're all like, we don't even know what you're talking about. And this is the outcome of those early conversations. And it's really exciting to see what can happen when we come together.
Great.
Michelle is the director of this project, so I'm glad she's here.
Great. Thank you, Joan. And I don't think for those that know our executive director, Kyle Kessler, it's probably not the first time that someone has referred to one of his ideas as crazy, but they generally work out. And I would be remiss if I didn't kind of give a little bit of background because this really was his brainchild. And he often refers to what he calls it Menninger in the aggregate. For those of you that remember the Menninger Clinic that used to be located in Topeka, Kansas, it was really nationally known as a true center of innovation for training and treatment and behavioral health. And unfortunately, when the Menninger Clinic left the state of Kansas, we lost some of that capacity for sure. So the overarching vision in developing a behavioral health center of excellence is try to get some of that back. I should say, I've got this definition up here on the screen. In general, a center of excellence is really a place where we are attempting to achieve leadership, best practices, research, and training by bringing together a team of subject matter experts. Now, in our case, we're not really talking about a brick and mortar entity at this point. Potentially it is our hope that several years from now that it will be its own self-sustaining organization. Until we're at that point, our association has really pledged that we'll continue to provide coordination and any kind of administration work to really get it up and running. What it really is in our case is sort of at the basic level, a really broad partnership in which that we brought together multiple entities, again, those subject matter experts, both from the provider and education arenas who have that expertise in behavioral health. Next slide. This is not a new concept or unique for Kansas, but I think we are doing it in a bit of a unique way. There are some other states, Nebraska being one, they have a behavioral health center of excellence and it's housed in a university. Ours is a little bit different. We really want to be as agile and have the ability to really be as innovative as possible. And to just be very blunt, to remove any kind of red tape or bureaucracy so that we can make forward progress and see some early success. But some attributes of what it looks like to be a successful center of excellence are really the access to the right expertise at the right time. I think when we get to sort of this slide with the membership list, you'll see that I think that we've clearly got that. Actionable ideas and strategies to date, and I think probably for the foreseeable future, the bulk of what we're working on really is workforce. I don't think it's a surprise to anybody on this call, that, you know, the state of Kansas as a whole is really experiencing a healthcare workforce crisis. And when it comes to behavioral health, I'm not quite sure what is the next superlative beyond crisis, but I think we're there. And as you all know, we're very pleased and excited about the regional hospital that is being planned, but that will also have a significant workforce need. So we're talking about how do we not only retain our current workforce, but how do we grow that new workforce so we can meet those needs throughout the community. We also are talking about research and innovation, how to generate knowledge around best practices, disseminate that, and again, quick delivery of results. Next slide. Now, why did we decide to start in Wichita? For example, our offices, we work in Topeka. But of course, we have members all across the state, but there's a few reasons that we really thought Wichita is the place to begin this work. Not the least of them being the new state hospital that is being planned and built. But also unique. Wichita's a very unique community in terms of the array of both providers and educators. So that's certainly one reason. Also, as we sort of look at the workforce trends across our association, oftentimes in terms of seeking training and an education or implementing new programs, oftentimes Wichita is an area where those begin and also filter out across Western Kansas into some of our more frontier communities. Our long-term vision is that the center, as it grows, that we may be able to either replicate or expand. Perhaps we can bring together a similar group of individuals or organizations in Hays and work with Fort Hays. Perhaps we can do something very similar in Johnson County, but we really felt like with the time and all of the work that's going on in the Wichita-Sedgwick County area, that this was really the prime spot to begin this work. Next slide. I should say our first official meeting was really only last December. So if you've heard the phrase building the plane while you're flying it, that's absolutely what we're doing. We're kind of figuring it out as we go along. But it's kind of amazing how much we have already accomplished in just a short, not even really a full 9 months since we first kind of had a first meeting. We've been working pretty closely with the Community Engagement Institute there at Wichita State University over the last couple of months in particular to start putting together some structure in terms of what is our mission, what is our vision, a charter, some long-term planning. You know, in December, I'll be very frank with you, we pushed them very quickly and said, we hope to put this concept in front of the state legislature, and we plan to make some asks, which means we've got to put together some asks probably in a couple of weeks. So we were at first very focused on putting together a policy agenda, which we have one of those, and I'm happy to share if anyone's interested, and some budgetary asks. Now, as about May, we started then focusing on this kind of broader planning. What you have in front of you is a small work group just completed their task of putting together a draft mission and vision. This actually hasn't even been shared with the full group yet because we meet every 2 weeks, and I just got this last week. And the full group, the full center will get to review this next week when we meet again. But you'll see, you know, they've identified the mission as being to promote innovation and rigor in mental and behavioral health and human services, to foster high quality statewide interprofessional care model of prevention, resilience, and quality of life for all. And that their vision is that South Central Kansas is a leader in behavioral health education, training, and service provision. Next slide. So we have about 15 organizations that have been very consistently participating and actively participating since we began. I've kind of grouped them a little bit. On the left side, these are not all providers, obviously, because we have not only our association, but the State Department for Aging and Disability Services, but also ComCare, Mental Health America, Substance Abuse Center of Kansas, and Ascension Via Christi. And then we also have all of our higher education partners who have all signed on and just been fantastic partners to date. Wichita State University, multiple degree programs within Wichita State or have been around the table. KU Med Wichita, the new Bioscience University, Friends, Newman. And then we also have representatives from the Kansas Community College Association as well as the Kansas Technical College Association. Those are also very key partners when we start talking about the various degree programs, not the least of which being nursing. And we put some focus on that, which I will get to here shortly in our budgetary ask. But this is the main core group as it stands to date. Next slide. And a little bit about who we are. We did kind of a brief survey of both our provider and our educational partners early on. And this is really who we are all representing. Employers in mental health and addiction, counselors, social workers, nurses, care coordinators, peer support specialists, case managers, psychologists, psychiatrists. We don't have enough of any of them. We need more for sure. And our other partners train and educate those very same providers. Next slide. What we hope to do as the organization matures and grows is be able to provide technical assistance where it's needed. We're very much focused on applied learning opportunities for students and how we can make available more internships and employment opportunities. One of the great things that has happened over the last several months is what we have found and what some of our members have voiced to us is that they've made connections just by virtue of being in the same room together. And in a couple of instances, developed some new internship opportunities for their students right there within Wichita that they didn't know they had the ability to do prior to this group convening. More focus on education. One thing that, within all of 9 months, we haven't gotten too deep into data research and evaluation, but that's on the agenda for sure. And absolutely, we'll continue to do advocacy at both the local and state levels. Next slide. In terms of very formal organizational structure, to give you an idea of where we are now, the Kansas Behavioral Health Center of Excellence we have official articles of incorporation filed with the Secretary of State. So we are technically an organization. We do have our tax ID, and we're working with some legal consultants to complete our application for nonprofit status through the IRS. This will be a 501c3 entity. Part of that process includes establishing our governing board and then our governing board adopting official bylaws. So that same group of members that I had on the previous slide, each of those groups will be sort of an appointing authority, and they will get to appoint a member to a governing board. But in addition to that governing board, we're going to continue to maintain the broader membership of all of the individuals who have been really actively participating and providing such great input and expertise as an advisory council. I can foresee in the future, perhaps there will be additional subcommittees, work groups, but there's certainly plenty of work to go around. But that governing board is really a key piece of the organizational structure. Joan mentioned I'm going to continue to kind of lead in a staff type role with the organization until if or when there's sufficient funding, perhaps someday, to hire someone, but I'll continue to staff the organization, and then we'll have this voting governing board with established bylaws. And we really hope that all of that will be in place no later than the end of this year. Next slide. So I mentioned some early successes. Toward the end of last year, we were granted a $75,000 kind of seed grant from Aetna Better Health. And that's what we've been using to date to just basically provide, we've got one consultant and a small contract with Wichita State to help us with some of the strategic planning and development work. But we also, as I mentioned, created a draft policy agenda. And we used that and brought forward some specific budgetary asks from the state legislature. And we were successful in having and securing a $5.7 million appropriation this fiscal year. That money flows through the KDAD's budget, and then it will be distributed to at least for this first year, if Community Behavioral Health, which is a 501c3 entity, subsidiary of our association, which will then disseminate the funding that is primarily or will be used for expansion of psychiatric residency programs there and the KU Wichita campus, as well as some addiction medicine fellowship programs, development or expansion of forensic psychology programs at Wichita State University. There's several pots of that funding that are targeted for specific applied learning opportunities. Think some practicums and some additional expansion of some behavioral health focus area under the Physician Associates program at Wichita State University. Paid internships. That's one thing that has been discussed quite a bit, both within our association and with the Center of Excellence, and the challenge in being able to pay interns. So having some funding to help support those students getting those real life work experience has been noted as very important, both from our providers and our education members. So that's a really key component of what we're working on. And then there's some funding, I think it's about 2.4 of the 5.7 that is earmarked for recruitment and retention bonuses, specifically for nursing faculty in 2-year degree programs. That's where the Community College Association, the Technical College, they'll be very key in working with us to get those funds disseminated. In many of our conversations, one big challenge that we discussed was not so much the difficulty in finding or recruiting nursing students, but retaining the staff. The average salary for the nursing faculty in the 2-year degree programs was $40,000, which you can imagine how difficult it is to retain someone who may have an RN degree and with the ability to certainly make much more than $40,000. So there's a pot of funding that will be set aside specifically for those 2-year degree programs to help retain the nursing faculty. And one thing that's very exciting, and I think, please correct me if I'm wrong, Deputy Secretary, but I believe this funding is now considered to be in the base budget moving forward. Next slide. Looking towards next year, we want to build on that success. We recently, just a few weeks ago, provided testimony to the leadership of KDADS to give them an idea of what we want to request for next year. And this is not, that total of about 8.6 million is not all new. It includes continuation of the 5.4 from the previous slide, because those are not one and done things. You don't just fund expansion of a residency program for 1 year. There are ongoing costs, but given the scarcity of psychiatrists in the state, that is definitely high on the list of priorities. And then there were a few additional asks that some of our partners wanted to add to our agenda, including expansion of a Master of Science in Family Therapy degree program, creation of undergraduate pathway to pursue licensed addiction counselor credentialing, reestablishment of the Wichita Collaborative Psychology internship program, stipends for Masters of Social Work students. Those are primarily the new ask, and again, just continuations from this year. And we'll spend quite a bit of time, I imagine, next legislative session, talking with legislators. Hopefully we'll be able to report back how the FY25 funding has helped. I mean, we're still early, but hopefully we can provide some testimony from our university partners in particular, where a lot of that funding is targeted to explain how it's helping them either grow their student body or recruit new students who are our future workforce. Next slide. And then I just wanted to talk a little bit about, what the members of the center have been saying. As I mentioned, very new, very much the focus has been on workforce strategies. And it's not going to be all about the budget all the time. We're beginning some conversations now with them around, are there policy issues that we need to focus on to remove any barriers to getting individuals into the workforce faster. We're beginning some talk around that. And I fully anticipate that we'll have some policy issues that we want to bring up during the legislative session as well. Multiple times, and I think I saw both Joan and Mary there in the room. So please feel free to add to these comments, but there have been repeated just comments and people saying how much they appreciate being brought together, even though they are all working together in the same community. Often they're still very siloed, and this has been a pretty consistent opportunity to talk about shared needs. We did we had a social work student working with us, and she did some targeted key informant interviews, and a lot of the themes were that just that appreciation of the networking opportunity that this provided, connecting with other organizations. And I think I already mentioned, one program there at Wichita State said, I found new internship programs for my students just by being in this room that I didn't know existed prior to these meetings, and just how coming together as a center has really helped them navigate between those silos. And, I also want to just express appreciation to all that have been participating. They've really kind of left those jurisdictional siloed mindset at the door. And it hasn't really been an issue of even debating over where funding should go. It's been very collaborative and a lot of consensus building. It's been really great working with everyone. Final slide, I think, is also my contact information. So if there's anything that you would like to know more about, or you want to contact me, you have my email address there. And I'm happy to try to answer any questions you may have.
Thanks, Michelle. Are there questions or comments for Michelle? I saw Joan first, Natasha, but
I just want to make an observation, having participated in this endeavor, is this is a room full of very, very busy executive level people. And when asked how often the group wants to meet, it was not any hesitation every other week to keep the momentum. And I think that speaks a lot to the priority workforce development is.
Mine's not a question necessarily, but more of like a statement or an inquiry. Member agencies, the Mental Health and Substance Abuse Coalition here in Wichita, Sedgwick County, they're working on a bunch of stuff, and there's a lot of us in the room that are affiliated with that group too. And I was just wondering if you guys had made a connection with them or not, and not to say that that is an appropriate fit by any means, but I know they're working on advocacy and data collection and some, universal databases, and they're putting financial resources into their efforts. And I just think maybe due to duplicated efforts or something, that it might be a good group just to reach out to inquire about what it is that they're doing. So
Michelle.
Absolutely. And I think that's the coalition that Don Schepler used to coordinate, correct?
Yes, that's correct.
Yep. And Dawn was very active participant in the center. And I know she switched jobs recently. And also Harold Casey is another member, and I think he sits on both. And so he's been talking about how can we coordinate those efforts. And that's certainly something that we want to do. It's not our intent to duplicate any efforts. So I'm not sure if there's a new coordinator necessarily.
I actually don't think they're, I could be speaking out of turn. So, but I don't think they're hiring. I think Misty Bruckner at PPMC and James and a few others are stepping in to carry that. Joan, can you confirm?
That's accurate. And I think there's enough of us that are on both that it's well represented, or not to duplicate.
Yeah, perfect. Because I think honestly, the Mental Health and Substance Abuse Coalition could back off maybe some of their initial efforts, given this group is working on it.
Yeah, that's been my impression too, being involved in both as well, that it does, not that people are landing in lanes, but it's a lot of overlapping. It's the same people in the room. And,
Sure.
and it's some of the, one thing that we have tried to do, I think those of us that participate in both, is kind of point out where there's an advocacy channel. When there's a dollar amount identified in one group or for one group, we're tying it back to the others as well. So I think that's gone pretty well at the scale that it's happened so far. So I think that's happening on its own, largely because of largely because of the work that the folks in the county have already done. Now this is coming on as I won't say a state initiative because it's coming from the association, but with a broader perspective, but it fits neatly into the efforts that folks in the county have already identified. That's been really cool actually to watch from the state perspective. Other questions for Michelle or other comments that I will say, Michelle, I think you're 100% right that people have kind of dropped, many people have kind of dropped their boundaries or their silos, with the exception of in professions. So, and not that it's bad, but the medical school faculty talk a lot about things that are related to medical professionals, psychiatrists, and that path. And when there have been discussions about nursing, it falls into kind of what's in the Board of Nursing jurisdiction or not, BSRB jurisdictions or not, and that's not bad. And I think it is kind of laying out the landscape people are operating in, which then comes back to some of the other recommendations and even some of the ideas that Taylor mentioned that the Policy Academy is working on. Where are those barriers? Where are those things that people get stuck because the license says you have to do 400 hours. Well, is it really need to be 400 hours or is it really 200 and 200 of practical experience? And then as opposed to what has been, the other thing I found interesting is when we find those things, people don't just assume that those are unmovable, unbreakable, impossible things to overcome. It's just, where's the right point to leverage that and make the argument. So I think that's been helpful as well to really call those things out. But the professional categories are still, and we're not going to ever lose that, I don't think, which is probably good. But that's one area that I do think broadening the base, which you've done, is addressing those, social work, marriage, family therapy, licensed positions, unlicensed positions, all those things where you start from the bottom up. Okay. Well, thank you for that presentation. Again, like I suggested to Taylor, as things keep developing, we may have you back to talk about the next thing or where, as things we talk about specifically things for the hospital. It'd be a good time to have you back as well.
Great.
But thank you for your time today.
Thank you.
So our last item for today is to look at draft recommendations. And so for those of you in the room, there's a couple of page handout that we put together. I emailed it to the group earlier in the week. If you can find it in your with the agenda and the minutes. And maybe just for reference, so in our report that we're going to submit at the end of next month, and in the interim report we did a few months ago, there was a place for recommendations. We made a few the last time about forming subgroups and advocating for to build the full 104-bed design, those kinds of things. So, and also moving our final deadline was another thing we recommended, and that happened. So we've got a good history of having recommendations in the report, and I think I did want to give you some language to look at and respond to. The areas that we've talked about, so we grouped them by kind of big category or large significant buckets of areas. One of them is catchment area, or the first one is catchment area in that document. And so in writing this, I tried to capture everything we've talked about so far and what the sub panels worked on, which first was that I don't really want to read all these, but I'm going to spend more time on the catchment area than others. But in everything we've talked about, the purpose this group has been very consistent about saying this is a hospital not just for residents and citizens in Sedgwick County, but for the region. So I wanted to say that. And then the sub panel said the catchment area ought to include, if we're thinking about a region, Sedgwick, Butler, Harvey, and Sumner counties. And I hopefully got those right. I checked my notes several times because that, if we're going to call out a catchment area, that would reflect the crisis, the catchment area for the crisis services in this area. So we called that out. And then the third element is, as we've talked about it, maybe there isn't a need to call that, to define that catchment area in statute this year, this coming session, but to look at other data as we open and think about the progress and reevaluate it down the road. So a recommendation that captures everything we've talked about, to see how much of it sticks. So that was what I am proposing, but I'm happy to modify, change, or take your comments or questions about that recommendation. Adding Cowley as a call out, because that would be in the right adjacent counties too. Any other thoughts about catchment area? I guess I would say, sorry, I'm not, this isn't your only shot to look at this. If you want to take it back and look at it and send comments, we can work on that. We will want to review and hopefully approve the final report language at our meeting in September. Greenbush has got a great draft of the kind of summary of what we've been working on, and we'll insert this as a separate section. Think about catchment area. Workforce development was another area of recommendation, again, that we've talked about. The ones that are listed here are the same ones that the workforce and training sub-panel recommended. I tried to look at them also with what's been approved by the legislature that Michelle was talking about from the Center of Excellence. It overlaps for the most part without the dollar amounts. The items are generally the same. But so you can look at those workforce development ideas, and maybe from the presentations, once you get them all by email, there may be something more specific that you want to add.
I would just add, on the second line, it says, if we're going to intersect those two groups, this one says 2, and I believe the Center of Excellence proposed and got funding for 3 additional residency slots.
Two or three.
Oh, 2 over the years, but 3.
Okay. Thank you. So that's workforce development, and there may be something more specific you would like to recommend there. Legislative recommendations, it's not a great descriptor of category, but the law enforcement subpanel had made a recommendation about requesting that the governor or legislature ask the Criminal Justice Coordinating Council or Judicial Council to do a review of the Care and Treatment Act. So we could make that as a recommendation in the report as it's described here, or using some other language. But that would be looking at the statute that allows us to involuntarily commit people to state hospital levels of care. And then the other item, and I don't know that it's really a legislative recommendation, but it didn't fit other places, that the State Board of Education in there looking at pathways for that, professional pathways in K through 12 education that can lead to high school or credit granting pathways, to look specifically at adding a behavioral health or counseling or mental health services pathway to the existing human services cluster when they open that up in 2025. That one, I think that came from the workforce group as well, as we talked to them, but that's a little more specific.
Scott?
Yes.
Yeah. So on the legislative recommendations, there's a statute already there that's been placed in here. So do we already have that statute, or is this something that was developed and we're looking at new statute?
For that for care and treatment, there's already a state statute that defines the criteria for initiating who has to initiate a care and treatment case, the criteria for evaluating somebody for a care and treatment order. So it'd be, what we'd be asking is that the Judicial Council or other group that reviews statutes to look at what's in the current statute and see if it fits current practice, or if there are suggestions from other public defenders, county attorneys, law enforcement that might, or CMHCs as well, they're involved in that process. We would want to change things in the statute, criteria, define processes that we'd need a statutory change to make.
Okay, so update it to what we need, and if
Yes.
it's not already, and maybe look at what other communities are doing, other states are doing as well, that fits the purpose that we're looking at. The second one for the Kansas Department of Education to develop behavioral health and counseling as a pathway. So I know there's classes. Are you talking about having a curriculum that that you can work with a community college as a pathway into a profession of, you know, whether it's LPN, psychology, whatever it is, like you would for STEM programs or such items?
I think, and others may be more expert at this than I am. I know others are. So it's at the high school level. It's kind of pre-degree granting, but so it would be more like a STEM program where there are defined classes that meet the requirements for engineering. The other one, the other pathway is I think it is called the Health Services or Human Services Cluster, where it's biology, anatomy, some chemistry classes, and I think there's another kind of pre-medical course. And if you take all of those or classes in that pathway, then you graduate with that as a precursor to an undergraduate program or associate's program. What we'd be looking for is either specific elements in that pathway that are behavioral health focused. So maybe you're not taking biochemistry, but you're taking psychology or introductory to social work or something like that, or creating a whole separate pathway that would be just for behavioral health that perhaps wouldn't have organic chemistry, but would have something else that would be more behavioral health related.
Okay, I understand. Also like a micro-credentialing of sorts as well, that could probably fall into that maybe eventually.
Yes.
Okay, I see that. I guess we don't have something like that, and I do think it's a really good idea to have it, because we do have it for a few. So it's not a new idea, but we don't have it in this specific sector. And
Right.
Another thing for you to bring to us, to the legislature, which would make it easier for us to grasp it, as well as for KSDE, see if other states are already implementing something like this. I would have to think so, because it seems like I don't know why we haven't done it before. For us to just start off with that and get your board members on board for us to do something at the legislative level.
Yeah, I think we've identified some other examples from other states where there's either a behavioral health pathway or behavioral health emphasis within their healthcare pathway, or it's a separate pathway.
Sounds good. Thank you.
There's a privatization item, which is again one of our charges, and I drafted what I think was our discussion over the last couple of meetings, that we would operate, the regional hospital would be a state hospital. We'd be responsible for, the state would be responsible for admission and discharges, but we could choose to contract for other services that are provided at the hospital as needed. And that there may be other language that the panel would want to propose that we could look at, but I was trying to capture what our discussions had been over the last couple of months. And happy to take all kinds of suggestions about that one. On coordination of existing services, again, this is one of the charges to the panel, and came out of the law enforcement subgroup. One about, we would recommend establishing a formal intergovernmental agreement among law enforcement entities, emergency services, fire, behavioral health providers, and KDADs to establish kind of the clear communication processes and expectations related to the operation of the new hospital. We don't do this at the other hospitals, although we've moved in this direction to have a clear understanding with who provides fire support, or when there's kind of the operational element of in case of a disaster, who do you call, and the continuity of operations. This would envision kind of more of a statement of principles with some sharing of what kind of resources do we need, who would be providing them, but laying that out in advance. As an agency, I would say we're supportive of that concept, and I think it builds on the partnership we've already had with Sedgwick County. And we know this is introducing a demand on resources, and just calling that out in advance would help us all plan going forward as we operate. The second item under there about requesting KDED's provide a report about agency efforts for youth in behavioral health crisis. This specifically came out of the law enforcement group as a request from some of the law enforcement folks that attended, just to learn more about behavioral health services for youth and gaps in that continuum of care. A little bit outside of our scope, but it's a good idea. And if the panel would want to continue to recommend that or make that recommendation, it's something that we would provide as an agency back to the group and available for distribution there. And then the last one that's in that kind of same coordination with existing services is recommending that we enter a memorandum of understanding with the biomedical campus, WSU KU biomedical campus, to just really have a formal relationship as they're standing up their building, starting operations, about training and research. And I think something we would do anyway, but it makes sense given other things we talked about. Let's see. Final one are budget recommendations, or items that seem more budget related. In the law enforcement subpanel made a recommendation about funding for regional case management and behavioral health providers to provide wraparound services, wraparound behavioral health services to decrease the need for law enforcement intervention. I think that's word for word what the panel or what the subpanel recommended. We can certainly recommend that to KDADs. Some of those things are already funded through the mental health center system. So I struggled a little bit with what the action was, but that is the recommendation that came to the panel. And then finally, about telepsychiatry and other supporting. I'm sorry.
I think I recall that was related to those high utilizers of service. I can't remember the specifics of it, but it was a special population that was being focused on.
And frequent flyers, or people that admit and discharge quite a bit, particularly through involved law enforcement. And then the last one came from the workforce panel, a recommendation about reimbursement for telepsychiatry and other support services for clinical gaps. Taylor mentioned that. I think even the centers talked about that as well. That would be nice if we had a dollar amount in mind. We did ask some of the medical school staff that brought it up originally, of what specific services would you want to see the rates increase for. Didn't get much progress on that, but that was the recommendation that came from the workforce group. That was my attempt at summarizing all of the recommendations we've gotten since we started meeting and to try to put words on all of them. I don't know that it's comprehensive. I don't know that it's everything, but that's where we're starting. So in the last couple of minutes that we have, are there kind of big areas that are missing, or things that you've thought about that aren't on this list that we need to work on some language for? Okay, so what I would leave the group with, and I'll send this around again with the other slide decks. That'll be a good opportunity to attach them together. I'll make the couple of edits that we've talked about today. But if you could give these a read through over the next couple of weeks, and there are wording changes you want to suggest, or again, things that you think are missing, I guess that's and if there's some that you find objectionable that you want to strike or don't want to see, all those three things would be good to know. But, and in particular, if there's something that's not on here that you want to make sure we're recommending about or the group's discussed, that would be good to get probably sooner than later so that I can get it out to the whole group and you can all look at it and think about it before we meet in September to kind of finalize it. Because if we meet the third week in September, we'll have a couple of weeks after that before the report's due on the 30th, but that's not a whole lot of time to make adjustments. So if you've got suggestions, concepts you want to work through or add, and get them to me in the next couple of weeks. We'll work on language so that the group can have that to review with the draft report before we'd meet on I don't remember what the date is now, but the 20th of September. Oh, so only 10 days. Okay. 20th of September. So in the next, after Labor Day, it would be, I won't say it's closed, but I would appreciate things for around then, so we have a little time to work on it and draft language.
Can I ask a really dumb question?
Of
Not
course,
related to maybe
as long as your
this-
microphone's on. Yes, it is. I think it is.
I like to actually turn it off and ask you after the meeting concludes, but just it might have come at a meeting that I couldn't attend this summer. Sorry. But I was wondering, has it been discussed about the hospital having a foundation? I know obviously a lot of hospital systems have foundations associated with them for grants and research or specials or what have you, maybe recruitment of faculty or faculty, but staff or those kind of things. And I'm just wondering, has that been discussed or is that applicable? Is that a terrible idea? That's not really something that you would recommend, but just given everything that's going on and, everyone talking about this crisis and we need to pour a lot of energy and effort into this. If a hospital foundation was set up, I'm wondering, would that help instead of it just being all on the state or, we have the set budget and we can't go above that, or as things continue to balloon a little bit, and again, it might not be applicable.
It's a really, really good question. The problem with it as a state agency is that we can't operate as a state agency and a philanthropy. So what we do on the other campuses is we have a patient benefit fund, or we have some private or 501c3s that are operated either by like our facilities for people with intellectual and developmental disabilities. The families there's a family parents association. And they have a foundation so they can donate money and do things to benefit the residents. Osawatomie's got the Osawatomie Friends of the Mentally Ill. That's a private philanthropy that raises money through a variety of different things, including membership, and they use that money to benefit patients. Parsons has a philanthropy that does other things to benefit patients, but the charge of a couple of those groups includes things that support the purpose of the hospital. So state agencies can't buy food for our staff. But when we have meals or want to do an event to recognize staff, superintendents can ask their foundations to support that. And we do it that way. So we can certainly do something that would benefit patients. And
that's kind of why I asked is the benefit of the employees. So work culture and just all of those extras that
sure,
obviously are probably not going to be able to be included in. So, and who would it be? This group, or would it be the staff once the hospital is, established to be discussing those kind of advisory or philanthropy, or who typically kicks those off? Like at Osawatomie, was it the families of the patients?
Yeah, it was families and some of the staff that a lot of them are retirees that run the group, but it's the staff that formed the group, or parents and family members of.
If there's enough interest, it might be something, and again,
that's a good idea
in the future, but it might be something that's worth setting up simultaneously as the hospital opens, because there's going to be a lot more support. There's going to be more eagerness to how do we get involved? How do we
Sure.
support this effort? And if there's no real avenue for people to do that as community members or what have you, medical professionals or otherwise,
Sure.
this might be a nice to do those simultaneously if someone had a desire to do that.
That's for the panel in particular, that's a great recommendation to make so that we don't lose track of it. Make sure that the governor it's directing me, I guess, but us to make sure we've got some kind of a foundation or nonprofit facility so that there's a place for that to happen.
Yeah.
I'll take a stab at drafting a recommendation about that.
Yeah,
That's a really good one.
it's a really good possibility of just with all of the media attention and everything going on that there might be a benefactor that wants to step forward to make a gift. And if there's not an avenue to do that, it might be a missed
Sure.
opportunity for the hospital to benefit.
That's a really good suggestion. Just to be clear, you all have contributed through your payment of state income tax over time to the development of this hospital. So I certainly,
You know what I
there's
meant,
no more,
Scott.
there's no more,
You know what I meant.
no more
Above and beyond.
contributions are necessary, but I appreciate the thought about it. But there are limits on what we can do as a state agency that our fundraising arms help fill in some of those gaps. So that's a really good thing to call out. Probably the other one, Melinda's here to help me remember about a citizens advisory group. We ought to set that up before we start operations. Great suggestion. Other comments or thoughts? Okay. Well, I will get these other two presentations sent out and do some updating to the recommendations list. If you can take a look at that and give me your comments back so we can keep working towards our final report in September. And we'll have more updates about the project next month. There aren't, guess I would entertain a motion to adjourn for today. Tasha and Joan move in second. Any objection to adjourning? Hearing none, we're adjourned for today. Thank you for your time. Have a great weekend. Thank you.